Hello and welcome to this afternoon's neurology webinar on vestibular disease in dogs and cats. My name is Mark Farrell and I'm a commercial manager here at Virtual Veterinary Specialists. At VVS, we're all about furthering the collaboration between first opinion vets and specialists. Our mission is to help you feel confident approaching every case, knowing you've got the support of a specialist team behind you. We offer referral level care right from your own practice. We want the VVS specialists to feel like an extension of your clinical team, people you know and trust. As well as our Halo live guided cardiac workups, we also offer live guided abdominal ultrasound, which includes, as a standard, real-time support from our internal medicine specialists. We also offer advice calls and reports in multiple fields, including neurology, and we are working hard behind the scenes to launch live guided neurology workups soon. And now it is my great pleasure to introduce our speaker for today, Dr. Sarah Butterfield. Sarah started her neurology journey with a rotating internship at Langford Vets, followed by a neurology internship at Fitzpatrick's. She then completed a residency at the RVC and is a European and RCVS recognized specialist in neurology and neurosurgery. Sarah has a particular interest in epilepsy, inflammatory brain disease, and neuromuscular conditions. We are very grateful to have Sarah on the VVS team, bringing with her vast knowledge as well as her enthusiasm and dedication to patient care. Now, if you have any questions as we go through the webinar, please would you add them to the chat box, and when we finish with the presentation, we'll go through those. So without further ado, I'll hand over to Sarah for today's talk.
Hi everyone, I hope everyone can hear me okay. Thank you, Mark, for the introduction. So welcome everyone, thanks for attending. Today, as we said, we'll be discussing vestibular disease in our cats and dogs. Oh. Lovely. So in terms of our lecture objectives, we'll be starting to review the anatomy and function of the vestibular system. We'll look over our examination and then look to see if we can differentiate between peripheral and central vestibular disease. We'll look to then come up with a sensible list of differential diagnoses in our most common conditions. And then following that, look at our diagnostic and treatment plans. So I hope you find this useful and become more confident with your vestibular cases following this lecture, but we will have some time for any questions at the end as well. So in terms of our role of the vestibular system, so this is our primary sensory system to maintain balance and sort of normal positioning with respect to gravity. We look to maintain position of the eyes, the neck, trunk and limbs in relative to the movement of the head. And it's also connected with our extraocular muscles responsible for reflex eye movements and tracking objects. So this is our primary system controlling essentially our balance and position in space. So in terms of anatomy, so it's broadly divided into our sort of anatomically and functionally into our peripheral and central vestibular systems. So peripherally means, i.e., essentially outside of the brainstem, and this involves our vestibular apparatus in our inner ear, so the receptors and axons of our cranial nerve 8 or vestibular cochlear nerve. And then our central vestibular system is composed of our 4 brainstem nuclei. So there are 4 either side of the medulla oblongata. And then our cerebellum, so specifically looking at the flocculonodular lobe and the caudal peduncle. So we have our proprioceptors, so these are our sacral, utricle and semicircular canals, and they detect the position and movement of the head and then send these impulses to the neurons of the vestibular ganglia. These then project to our 4 vestibular nuclei that we mentioned through the internal acoustic meatus, where this information is integrated and connected to these nuclei of the cranial nerves that are responsible for the eye movement. So they additionally project to our ipsilateral extensor muscles of the limbs, so causing ipsilateral facilitation of the extensors, and the ipsilateral flocculonodular lobe of the cerebellum as well. So in terms of our middle ear, this consists of an air-filled tympanic cavity, our three auditory ossicles, so our malleus, incus, and stapes. The tympanic cavity itself is lined by squamous or simple cuboidal epithelium. And then we also have sort of our cochlear round window, which is located in the caudolateral portion of the what we call the promontory and covered by a thin membrane. And then we also have our vestibular oval window as well. Now, the image on the right, this is a typical T2 weighted transverse MRI image. This is at the level of the tympanic bulla. And so this is a common sequence that we use when we do our MRI scans. So the CSF in this scan appears white and air appears black. So you can see the two tympanic bulla that are indicated by those two blue arrows. This is just coming off from our horizontal ear canals, going into these air-filled cavities. The bright white structures that are immediately above these tympanic bulla are inner ear. So it appears white because essentially it's sort of filled with fluid that's a little bit like CSF. So it shines bright on this particular scan. And then in terms of the inner ear, so this is housed within our bony labyrinth in the petrous portion of the temporal bone. So this bony labyrinth contains our membranous labyrinth, and this is with its sensory organs responsible for our hearing and balance. So we have three functionally related parts of the inner ear, the first being the semicircular ducts, and these are containing our hair cells that detect acceleration of the fluid known as the endolymph, caused by rotation of the head. There are three ducts within our semicircular canals, and they each have this little sort of widening at the bottom known as the ampulla, which contain our sensory crista. These semicircular ducts are orientated at right angles to each other, and the rotation of the head around any plane causes the endolymph to flow into one or more of these ducts. Then we also have the utricle and the saccule. So these contain hair cells in the macula and respond to linear acceleration of the head and its static position. And then the third part is the cochlear duct and containing the organ of Corti involved in hearing. So slide 8, this is just to demonstrate the proximity of the facial nerve in particular to the vestibulocochlear nerve. So as you guys, I'm sure, are aware that we can see sort of facial sort of neuropathy signs associated with vestibular disease, and this is due to the proximity of this nerve to the vestibulocochlear nerve anatomically. So the facial nerve provides motor innervation to the superficial muscles of the head, the face, the external ear, and as well as the caudal belly of the digastricus masticatory muscle. It leaves the cranial cavity via the stylomastoid foramen, and it's accompanied, as I said, by the vestibular and cochlear nerve. And when it does, it enters the facial canal, it opens into the middle ear, and it's located near sort of the vestibular window. So just in terms of an overview of the neuronal connections that form the peripheral and central vestibular systems. So we mentioned that the receptor organ, so the macular receptors of the saccule and the utricle are located within the vestibule and the crista ampullaris of the semicircular duct, located within these semicircular canals. And this is all to do with sort of locating the positioning of the head in space. Now, our information goes via our four vestibular nuclei that I said are mentioned, located in the medulla oblongata. And then we sort of have several pathways from there. So these are either via the ipsilateral vestibular spinal tracts, and these are going to our extensor muscles of the limbs and are facilitatory to these limbs. They also go via something called the medial longitudinal fasciculus. So these are to our cranial nerves, controlling the movement of the eyes. And these are cranial nerves 3, 4, and 6. So if you guys remember, the oculomotor, the trochlear, and the abducent nerves. So the oculomotor nerve goes to our ipsilateral, dorsal, ventral, and medial rectus muscles and our ventral oblique. And it also contains the parasympathetic part of the oculomotor nerve as well. Then we have our trochlear nerve, which goes to the dorsal contralateral dorsal oblique, and then our abducens, which goes to the ipsilateral lateral recti and the retractable by muscles. So I tend to remember where the trochlear nerve goes and the abducens, and then the oculomotor nerve sort of goes to all the others essentially. So then if we have any lesions of the oculomotor nerve, they typically result in a ventrolateral strabismus, as well as they can result in an internal ophthalmoplegia, so a dilated pupil that's non-responsive to light due to the parasympathetic component. The trochlear nerve typically causes a dorsolateral strabismus of the contralateral eye because it's a cranial nerve that crosses over. And then the cranial nerve 6, so abducens, typically causes sort of an ipsilateral, what we call convergent strabismus, but it's incredibly rare to find lesions affecting the trochlear or abducens nerve alone without other neurological deficits. So in terms of our clinical signs of vestibular dysfunction, so of course we have our common signs, and typically what's associated with the vestibular system is our head tilt, nystagmus, ataxia, and strabismus. So our head tilt being sort of an abnormal rotation of the head along what we call the median plane, causing one ear or eye to be lower than the other. It's important to distinguish this from a head turn specifically, where the head is in a normal rotation, but the nose is pointed sort of one way or the other. And this is often a result of forebrain dysfunction rather than vestibular. And the reason that we see this head tilt is a loss of anti-gravity muscle tone on one side of the neck, causing the head tilt to go towards that side. And it typically goes towards the side of the lesion or the affected side. The occasion where that doesn't happen is typically known as paradoxical vestibular disease, and that's when there are specific areas of the cerebellum that are affected, but we'll come on to discuss that in a few slides' time. In the case where we have bilateral vestibular signs, we don't typically tend to see a head tilt. However, we do tend to see sort of these wide excursions of the head where the head sort of moves from side to side without a specific tilt as such, but it has sort of this pendulous movement from to either side. In terms of the nystagmus, of course, this means any sort of abnormal eye movements typically occurring at rest, and any abnormal eye movements that are occurring without any sort of stimulation is always pathological. The ataxia, this is defined as an uncoordinated gait. So remember that we have 3 types of ataxia, vestibular being one of them, but the other 2 being proprioceptive and cerebellar. And a vestibular ataxia is characterized by a tendency to lean, fall, or roll, usually in the side, sort of in the same direction as the head tilt, usually to the same side as the lesion. Sometimes it can be a little bit difficult to distinguish between these types of ataxia, but there are definitely those kind of key features of vestibular that we can see. In terms of other signs, as we mentioned, the strabismus is typically what we call a positional and ventrolateral strabismus. So this is an abnormal eyeball position. Usually when you elevate the head, you'll notice that one eyeball sort of drops down into that ventrolateral position. In terms of posture, we usually see a wide-based stance because they're off balance, so their sort of compensatory move is to have a wider base to steady themselves. They can have a crouch posture, particularly cats. They often go right close to the floor and have a reluctance to move. And usually we can see some circling as well, which is quite often towards the side of the lesion and is often described as tight circles. We can see circling in forebrain disease as well, but this is often sort of described as wider circles and is often in association with other forebrain signs such as sort of abnormal mentation or pacing behavior. If we do sort of think the vestibular system is involved, depending on the cause, we can see additional signs such as itching of the ear, caused by things like otitis externa. And then we can also see other signs such as nausea and vomiting due to involvement of the sort of vomiting centers with the vestibular system. And the reason that we often see sort of these unilateral lesions is that sort of a lesion on one side of the vestibular system prevents activation of that one side of the vestibular apparatus. And so those ipsilateral vestibular nuclei will not be excited as much as the other functioning side. It causes an imbalance and then leads to sort of facilitation of extensions on the unaffected side and lack of extensive facilitation on the affected side. And so this manifests as things like a head tilt, leaning and rolling from the normal side to the abnormal side. So in terms of nystagmus, as we mentioned, this is an involuntary and rhythmic oscillation of the eyes. So we can have normal and abnormal. So our normal nystagmus is our physiological, and we measure this as part of the vestibular ocular reflex, also known as the oculocephalic reflex. And this is when we move our patient's head from side to side, and we essentially monitor that there is normal movement of the eyes in association with movements of the head. And then we have our pathological nystagmus. So this can be resting or spontaneous. So that's occurring when the head is in a neutral position and is always present, or it's positional. So it's induced by holding the head in a certain position. Sometimes we can see this in patients where you don't really notice that they've got a nystagmus until you sort of put them on their back, for example, and then suddenly you can see it. So it's always important to remember when you're examining your patients. So typically when we see a pathological nystagmus, we tend to see what we call a jerk nystagmus. So we have a fast phase and a slow phase. And we always use that to help us distinguish localization on our examination. And often the fast phase of the nystagmus is away from the side of the lesion. We can also see sort of what we call horizontal in terms of the plane of the nystagmus, vertical or rotary, and as well as sort of a nystagmus that can change position with changing position of the head as well. And the latter are typically associated more so with a central lesion rather than peripheral. There's also been sort of studies looking into the rate of the nystagmus. So typically fast nystagmus, specifically over 66 oscillations per minute in this one study, is more associated with a peripheral lesion rather than a central. And I've just mentioned these other two forms of nystagmus that are not very commonly seen, but worth knowing about. So one is called pendular. So this is small symmetrical oscillations of the eyes. The reason it's pendular is there's not a fast phase or a slow phase. It just goes to either side and can be quite rapid in terms of when you see it. This is not anything necessarily to worry about. It is often described in our fancy cat breeds, so Siamese, Burman, and Himalayan cats. And this is to do with an abnormality of their ocular pathway, but these cats present otherwise neurologically normal. It's present from birth and shouldn't necessarily cause any problems. The other type of nystagmus I've mentioned is something called convergent retraction. So this is a very specific type of nystagmus that has been described in a few dogs. And I'll show you a video in a moment of it. And the dogs that this has been described in, and it's well sort of described in people, is associated with something called dorsal midbrain syndrome. So lesions affecting a specific region of the dorsal midbrain. And then the dogs that are affected all were treated for a suspected vascular accident of this region. So this is a video showing sort of performing the normal vestibular ocular reflex. So you're going to hold your patient and move them from side to side as you monitor the movement of their eyes. Now, I usually often elevate their head, so I might do it from behind as well, and elevate their eyelids a little bit as well, just so you can get a better look at their eye movements and eyeball movements as you do it. And then in terms of pathological nystagmus, so on the left, we have an example here. So this is a dog with right lateralized vestibular signs and a right head tilt. You can see he's got a horizontal nystagmus with a fast phase to the left. And then the dog on the right is an example of, as I mentioned, this sort of rare convergent retraction nystagmus, where you can see sort of this simultaneous convergence of the eyeballs and retraction into the globes as well. And as I mentioned, this is something known as dorsal midbrain syndrome. And again, this dog was treated for a suspected vascular lesion in this region. So other clinical signs that we can see, so as I said, a strabismus, so typically an abnormal position of the eye relative to the orbit, that's usually ventrolateral and positional in cases with vestibular disease. So you might not actually notice it when you're looking at the patient, and you only notice it when you lift the head and elevate the head, and you notice that that eyeball sort of drops down into that ventrolateral position. We also mentioned the presence of facial neuropathy due to the close association with the facial nerve, so paresis or paralysis of muscles of facial expression. We can see things like neurogenic keratoconjunctivitis sicca for the same reason, and then Horner syndrome. So as well as the facial nerve, the sympathetic supply to the eye is also in very close association to our vestibular cochlear nerve. So when we have lesions affecting the middle ear, then we can certainly see a concurrent Horner syndrome as well. And if you guys remember, there's kind of four main parts to a Horner syndrome. So a miosis, i.e. a constriction of the pupil, a ptosis, so drooping of the eyelid and a reduced palpebral fissure, enophthalmos, where the eye appears sunken, and then the third eyelid protrusion as well. And as I mentioned earlier, bilateral vestibular signs, so we can see lesions affecting both peripherally or a more central localization. And we see loss of balance and ataxia to both sides, a crouched posture, wide head excursions, and we can, as I said, see this with things like bilateral otitis media interna, or even systemic causes, including kind of toxic metabolic causes like metronidazole toxicity or thiamine deficiency. So just to remember, as we said, anatomically, we're considering our peripheral versus central disease. And so then we look on our examination, it's important that we try and sort of clinically differentiate between each location in terms of what might be going on. Now, in terms of this, there are certain things on our neurological examination that we can do to try and determine whether it's more likely peripheral or central. And so in terms of peripheral disease, as we mentioned, it's affecting the vestibular part of the cranial nerve 8, located within our petrous temporal bone. So in terms of their mentation, these patients should be alert and responsive. They can be incredibly disorientated, and so it can be a little bit difficult to distinguish sometimes if their mentation is truly affected, but otherwise it should be sort of fairly normal. They shouldn't have any proprioceptive deficits, so when we do our posture reactions, we shouldn't see any deficits with those. The head tilt is typically towards the side of the lesion, and as we mentioned, additional cranial nerve deficits include facial paresis and Horner syndrome, the sympathetic supply to the eye. The nystagmus is a less useful indicator of whether a lesion is peripheral or central, because you can have any, but typically we tend to see a horizontal or rotary with a fast phase away from the side of the lesion. Now, in comparison with central disease, so as we said before, this is lesions affecting our vestibular nuclei within our brainstem and or the cerebellum. And so typically we tend to see depression of consciousness. And this is because there are two main areas within the brain that are affecting mental status, and one is our forebrain, and then the other is our brainstem containing the ascending reticular activating system. And so if we have a lesion affecting our vestibular nuclei in the brainstem, quite often we can see a disrupted or depressed mental status, i.e. obtunded or even stuporous. In terms of proprioceptive deficits, we don't have to have these, but we can see an ipsilateral paresis or posture reaction deficits on the ipsilateral side to the side of the lesion. Again, a head tilt towards the lesion. And then because the brainstem is affected, we can see other deficits of sort of the cranial nerves where they have nuclei in the brainstem as well. So typically cranial nerves 5 to 12, apart from the facial that we mentioned. And again, regarding the nystagmus, it tends to be it can be more vertical, rotary. It quite often changes rotation with sort of changing the head position, but it's sort of a less specific indicator with the nystagmus. And then we mention our paradoxical vestibular as well. So in terms of our lesion location, so these are very specific regions of the cerebellum that are affected. So our floccular nodular lobe of the cerebellum, or what we call the caudal peduncle. So the cerebellum is attached to the brainstem via 3 peduncles on either side, and it's when the caudal one is affected. Now, because of that, and because of that is not where the pathways for our sort of mental status are. Again, they can be disorientated, but their mental status should usually be unaffected. They can have ipsilateral postural reaction deficits, but they have a contralateral head tilt. And so that is where it doesn't fit on your examination if you have deficits on one side and then a head tilt to the other. And so this head tilt is actually away from the lesion. They shouldn't really have any other cranial nerve deficits. And then quite often they do have additional cerebellar signs. So these are things like dysmetria or hypermetria in terms of their gait. They can have things like a head tremor or a truncal sway as well. And it's important to note that your examination is unfortunately not 100% accurate. So in this particular paper, they mentioned it can be accurate in up to 98% of cases that are localized to central and around 77 in those that are peripheral. So if you have deficits that are suggestive of a central lesion, it's very, very likely to be central, but it's more common that you might have a peripheral lesion or one that localizes peripheral that is actually central. So in this video, we've got a little cat that was diagnosed with otitis media interna, so on examination localized as a peripheral vestibular disease. So you can see this cat has a right-sided head tilt, has a tendency to sort of fall and lean to the right side with quite a marked vestibular ataxia, but actually doesn't have any evidence of paresis. In comparison to this cat, so this cat localized central vestibular on examination. So you can see again a right-sided head tilt. And although it's predominantly in the cat with in the leg with the intravenous catheter, you can see that this cat is spontaneously knuckling on its limbs on the right side, which is more suggestive, as you said, of a central lesion. So in terms of our differential diagnoses, so we have lots for vestibular disease, but it's important to note the most common. So in terms of peripheral, we can have things like congenital vestibular disease. So it's always worth noting if you've got a very young patient presenting with vestibular signs, worth checking if it's a breed that is affected by congenital vestibular disease. We know that there is an association with hypothyroidism from a metabolic point of view, so we do often check their thyroid profile in dogs with vestibular disease. We can see tumours of the middle and inner ear, but most commonly we're going to see otitis media interna. We can see polyps in cats in particular, and then idiopathic vestibular disease as well. Of course, we can see toxic causes. Usually they have a clinical history suggestive of that, as well as trauma. And then regarding central causes, very uncommonly, we can see sort of neurodegenerative diseases such as lysosomal storage disorders. We can see these unusual, anomalous sort of abnormalities where we can see specific little cysts, for example, develop affecting the vestibular system, and things like hydrocephalus, which can also cause vestibular signs as well, although less commonly. Thiamine deficiency is always a very important differential, particularly in cats, to not forget. But the most common causes of central vestibular signs are brain neoplasia, so whether they are primary or metastatic, and MUO, so our non-infectious inflammatory disease of the CNS, and also FIP in cats. So in terms of sort of what we using our clinical reasoning to try and determine what is most common, remember that we can use the onset and progression of the clinical signs to determine what's going to be more likely. And this isn't just associated with vestibular disease, this is with all neurological diseases that we use this. And so remember, say you've got an older patient with slowly progressive clinical signs, and we're a bit more concerned regarding neoplasia. Acute onset, rapidly progressive, are typically seen with infectious inflammatory disease. Waxing and waning signs are quite often seen with metabolic disease, such as thiamine deficiency. And then usually with trauma and vascular, we have quite often a peracute onset, and with trauma, even sort of a known history suggestive of some kind of traumatic event. And then just remember our little DAMIT-V acronym to work through whenever you have a neurological case. So in terms of common causes in dogs, so as I mentioned, sort of idiopathic and infectious otitis media interna are two most common in dogs. And this is taken from a paper discussing sort of our clinical reasoning in canine vestibular syndrome, which is a very useful paper to read. And this is taken from a study of 239 dogs in the UK. So they also found sort of various associations in terms of idiopathic disease, for example. So they tended to be older, at a higher body weight, with improving clinical signs and a pathological nystagmus, facial nerve paresis, etc. And whereas infectious are typically younger, male predisposition associated with Horner syndrome and a peripheral localization. As you can see, idiopathic and infectious are much, much more likely than the other causes, but definitely worth noting kind of our main causes of central, as we mentioned, MUO and neoplasia being the most common. And this is a little paper from kind of a very similar team looking at feline vestibular syndrome and what presenting factors are important here. And again, otitis media interna being the most common over idiopathic in cats, whereas it's the other way around in dogs. But those two remaining the most common causes, as well as other things to consider, as we mentioned, FIP specifically in cats, and thiamine deficiency seen more commonly. And there are also sort of various associations that are seen more consistently with some of these diseases. So now we're going to come on to some cases just to try and put everything that we know into practice. And so first of all, case number one, we have a 10-year-old male neutral Cocker Spaniel. So the clinical history is the owner found this dog at home with a marked left-sided head tilt and unable to walk unassisted, that had occurred only within the last few hours with no other kind of no previous medical history and no history of ear disease. So on your neurological examination, the mentation is disorientated but alert. The posture, we've got a left-sided head tilt. The gait, we are non-ambulatory, i.e. unable to walk unassisted for 10 steps. We've got a marked vestibular ataxia, attempting to lean and roll to the left. And then we have our postural reactions, which are actually intact in all four limbs. And in terms of our cranial nerves, we have a horizontal nystagmus with a fast phase to the right, an absent menace response on the left with intact vision, and an absent palpebral reflex on the left as well. So I'll just play this video, which shows you this nystagmus in this patient. So I'll just give you a moment to have a little think about what localization is most likely. So our localization for this patient is left vestibular without signs of central involvement. So this patient is normal in terms of mentation without postural reaction deficits, has a very typical nystagmus of a peripheral patient, and we don't have kind of additional clinical signs other than this, this cranial nerve involvement. And in terms of our likely differentials, as we just talked about, idiopathic vestibular or otitis media interna are going to be our most likely, based on our peripheral localization, with central causes being less likely, although we can't completely exclude. So how can we explain the absent menace in this patient? So this is a dog, a different case, so it's actually on the other side, on the right side. But if you have a look at this video, you can see that we have an intact palpebral reflex and menace response on the left, but we do not have the same on the right. However, when you do menace this patient, you see a retraction of the globe and the patient does appear visual. So this is suggestive of a facial neuropathy, i.e. we don't have the motor component of the palpebral reflex in order to actually blink the eye when it's tested. And that's tested as part of the palpebral reflex as well as the menace response. And we know that this dog is visual and we see retraction of the globe when we do the menace. So the sort of sensory afferent optic nerve is working, but the efferent part of that reflex, the motor facial nerve, is not. So this dog is unable to blink as well. So in terms of investigations for this patient, so this dog had blood work done, so hematology, biochemistry, and a thyroid profile. As we mentioned, there is an association with hypothyroidism that has been previously sort of documented in the literature. It had an external ear examination, which didn't document anything abnormal. And in terms of imaging, there are sort of a few options that you could consider. So radiographs, I don't tend to bother with because I don't find them particularly useful. And I think you do have to be quite skilled in order to really interpret radiographs of the tympanic bulla. So preferentially, we'd usually go for a CT scan of the head or an MRI scan. Now, usually these, of course, are quite often performed at a referral level. However, it's become increasingly more common that people might have these available in practice. CT scan being usually cheaper, a quicker scan to do, particularly if you've got an unstable patient. And usually we get a good idea of what's going on in the kind of peripheral system in terms of the tympanic bulla. However, the MRI scan is going to be much better at looking at the nerves in particular. And so that's what this dog had. And we did an MRI scan of the brain and didn't find anything abnormal. Everything looked sort of normal with this patient. If you do see sort of abnormalities within the middle ear, then obviously you could also consider doing a myringotomy as well to sample for sort of fluid and bacterial culture and cytology. But in this case, all that we did was diagnose idiopathic vestibular syndrome with a left facial neuropathy in association. And in terms of treatment, this is typically supportive with meropenem and ondansetron, ocular lubricant due to the facial neuropathy and the inability to blink. And these dogs usually start to improve spontaneously within a few days. Quite often they can have residual deficits, so head tilt and ataxia might remain long term, and relapses are possible in these patients as well. So case number 2, we have a 5-year-old male-neutered French bulldog. So this dog presented with a 3-day history of acute onset and progressive right head tilt and ataxia. The dog also had 2 episodes of vomiting and had been previously treated for atopy and otitis externa. So on examination, this dog's mentation was appropriate. We have a right-sided head tilt, vestibular ataxia and leaning to the right, and normal posture reactions. Again, we have a horizontal nystagmus with a fast phase to the left. So I'll just give you a couple of moments just to consider your likely localization. And we'll just watch the video as you can see demonstrating this dog's right-sided head tilt and horizontal nystagmus. So in terms of localization, hopefully you guys agree. It's a right vestibular without signs of central involvement for the same reasons as the case before. So in terms of investigations and likely differentials for this patient, I think based on the breed and what we tend to know about them, and particularly a history of otitis externa, I'd probably put otitis media interna higher up the list than an idiopathic. And we know that these dogs also can get a primary secretory otitis media as well. So this is more a sterile process of sort of fluid within the ear, also termed glue ear, particularly in humans. And again, central cause is less likely based on our examination. Now, in terms of investigations, this patient had blood work, an ear examination, and again had an MRI scan of the head and CSF sampling. And what you might be able to appreciate from this MRI scan here is that we have, again, T2 weighted images at the top here that show this T2 weighted hyperintense material within this tympanic bulla, as well as this sort of diffuse and ill-defined T2 weighted hyperintensity of the soft tissues surrounding the bulla as well. And actually, you can see in the associated brainstem that there is also a region of T2 weighted hyperintensity sort of just adjacent to the bulla as seen with the red asterisks. And then the two slides below, these are pre and post contrast. So you can see in the right bottom image, so following contrast administration, we see marked contrast enhancement of the paraoral tissues, of the material within the bulla, and then of the lesion within that brainstem that's adjacent as well. So actually, this dog was diagnosed with a right otitis media interna, but also intracranial extension. So this dog had an intraaxial abscess and associated meningitis, so otogenic in origin, and a paraoral abscess to account for all that soft tissue change. And so even though this dog localized as peripheral, he certainly had evidence of central involvement on his scan. So we took a CSF in this dog, and as you can see, there's lots of abnormal cells here. So this is termed a marked neutrophilic pleocytosis. So these are all neutrophils in the CSF. And these images are highlighting intracellular bacteria as well. So in the first three images, we can see intracellular rods, and the bottom two intracellular cocci. And then also the additional things that we tend to test on the CSF are protein and total nucleated cell count, which you can see are markedly elevated in this patient. Interestingly, despite seeing bacteria and having such abnormal CSF changes, the culture of the CSF was negative. And this is often the case, unfortunately. It's an inherently difficult fluid to get a positive culture from. So actually, quite often it's not very helpful for that reason. And otitis media interna, so as you said, it's one of the most common causes of peripheral vestibular disease in animals. Usually an extension of otitis externa, however, we can get it from other sort of sources like the oral cavity and even hematogenous spread. And it's pretty uncommon that it causes meningoencephalitis, but it's definitely not impossible. And we've certainly seen it in a higher proportion of French bulldogs in particular. And in terms of treatment, usually we have a prolonged course of antibiotics. And as I mentioned, a myringotomy, but however, this can sometimes be a bit challenging based on patients like French bulldogs having particularly stenotic ear canals. It can be very difficult actually to perform, or just surgical debridement. So either sort of a lateral or ventral bulla osteotomy. And it's sort of the same in cats, typically having a VBO. And this, just for your sort of reference, is a CT scan of that same region, sort of at a similar level, where you can see the normal air-filled bulla on the right of this patient, but sclerosis and soft tissue opacity within the tympanic bulla on the left. So those are kind of the changes that we might expect in a CT scan. Now going on to case 3. So we have a 3-year-old female neutered pug. So this dog presented with a 2-day history of acute onset and progressive ataxia, progressing to an inability to walk and a left head tilt, and a single episode suggestive of a generalized tonic-clonic seizure. So in terms of this dog's mentation, the dog was obtunded, had a left head tilt, was non-ambulatory tetraparetic with a vestibular ataxia, and spontaneous knuckling on the left thoracic and pelvic limbs, with absent postural reactions in these limbs. And again, had a rotary nystagmus with a fast face to the right. So in terms of this patient's localization, hopefully you guys are comfortable with recognizing that we have several indications of central involvement in this patient. And so we would certainly consider a left-sided central vestibular, but let's not forget in this dog's clinical history that that he's also had an episode consistent with a seizure, which does not originate in the brainstem. So any patient with a seizure history is a localization of forebrain. So actually we'd have to give this patient a multifocal localization. Then in terms of our most likely differentials for this, so definitely infectious inflammatory is going to be high on our list. This is an acute and rapidly progressive clinical history. In a young dog, and particularly a pug, we definitely have MUO on our sort of highest list of differentials, given the central localization. And then less likely, mainly based on this dog's signalment, but neoplasia is definitely on our list as well. And so this dog had blood work, including a CRP and an MRI scan of the brain. So as you might be able to see from these red arrows included on the MRI scan, these T2 weighted images, that we can see this sort of marked focal, ill-defined hyperintensity of the brainstem at this level. And we can see actually in the forebrain as well, there are multifocal asymmetrical lesions, which is very typical of a meningoencephalitis. So as I said, we have these asymmetrical T2M flare, which is an additional MRI sequence that we do, intraaxial lesions, so lesions affecting the brain itself with variable contrast enhancement. It's very common for us to see raised intracranial pressure in these patients due to the mass effect of this focal inflammation. And CSF-wise, if we do take it, i.e. if we are not worried regarding raised intracranial pressure, we typically see a different cell type to an infectious cause. So we see a mononuclear pleocytosis rather than a neutrophilic. Now, interestingly, blood work in these patients is usually very normal, including a CRP. So even though we consider this a marked inflammatory response, it is confined to the CNS, so it's not a focal inflammation that we can see with other conditions. Sorry, a systemic inflammation. So in terms of MUO, so as I mentioned, this meningoencephalitis of unknown origin, we could talk a lot about this condition, but essentially it's a non-infectious inflammatory condition of the CNS, usually affecting our young to middle-aged small breed dogs. However, we can see it in larger dogs as well. And these are acute and rapidly progressive clinical signs. They are dependent on the lesion location because really this inflammation can set up anywhere in the CNS. But quite often we have brainstem clinical signs. Now, MUO is an umbrella term used because it does sort of encompass these various subtypes. So GME being our granulomatous meningoencephalitis. And we have three distinct forms of GME. So this is either focal, diffuse or disseminated, or specifically optic neuritis, where those patients typically present with acute onset blindness. We have necrotizing leukoencephalitis, previously termed a Yorkie encephalitis because of their predisposition to this condition. And then NME, so necrotizing meningoencephalitis, also previously termed pug encephalitis. And very rarely we can see eosinophilic encephalitis as well. However, this MUO, the subtypes are based on histopathological diagnosis, and of course we usually are not biopsying the brain. And so we use this umbrella term to encompass all of them, because otherwise you can only really make a diagnosis post-mortem. We do have sort of a criteria that has been described in a previous paper, sort of to include these patients. So usually they're over 6 months. They have multifocal CNS signs, so either evident on their examination or on the MRI scan. They have this mononuclear pleocytosis, and they have negative infectious disease titers. Now, it doesn't necessarily matter in terms of treatment because we tend to treat them all the same with immunosuppressive steroids, plus minus cytarabine treatment, so sort of a chemotherapy treatment. And there is sort of this couple of papers discussing the possibility of radiotherapy and treatment with these patients as well. The thing that it might change would be their prognosis. So we tend to consider those with necrotizing lesions tend not to do so well as those with GME. And the prognosis can be quite variable. It tends to be better if they show signs of neurological improvement within the first 72 hours, but still up to 33% die within the first week of diagnosis, and up to 44% within a year of diagnosis. So we still have to, unfortunately, be quite guarded in terms of these dogs' prognosis. And I mentioned sort of previously termed pug encephalitis because pugs do tend to be predisposed to this NME form. They're usually younger at presentation compared to GME, which are usually 4 to 8 years old, compared to these guys being less than 4. Seizures are common due to involvement of the occipital and parietal lobes. Herniation is common as well. And as I said, the prognosis tends to be considered more guarded. Now, there are several kind of papers looking into different prognostic factors, which you can sort of have a little read up on, but these can involve things like decreased mentation on presentation, the presence of seizures, lesions of the caudal cranial fossa, and foramen magnum herniation as well. And then on to case number 4. So we have our 5-month-old female neutered ragdoll. So this little kitten had a 2-month history of waxing and waning in appetence, PUO, and slow growth, and a 1-week history of acute onset and progressive ataxia. So if I just play this video for you, you can see that this patient has sort of a marked ambulatory but marked vestibular ataxia, falling to either side and more to the left, with reduced postural reactions in the pelvic limbs and a rotatory nystagmus, which changed direction with the position of the head. So this patient localized to central vestibular with sort of a slight left lateralization. And so in terms of our differentials for this patient, so as we mentioned, acute onset and progressive infectious inflammatory disease is always going to be on our list. And this is a typical signalment for a cat with neurological FIP, so an infectious cause. And neoplasia, so at this age, we'd really be considering something like lymphoma. I have also mentioned metabolic, so we can see encephalopathies associated with things like portosystemic shunts in young patients. However, they should be sort of bilaterally symmetrical, the signs, and that's the same with thiamine deficiency as well. And very uncommonly, we can see sort of congenital abnormalities as well. So in terms of investigations, this patient had an MRI scan done, as well as blood work, which documented a non-regenerative anemia and a low albumin to globulin ratio. So we were already quite suspicious of neurological FIP. And then we performed this MRI scan, which has very sort of specific findings that have been described in cats with FIP. So this is things like what we call ventricular megaly. So you can see dilation of the ventricular system with this CSF. We can see syringomyelia, so sort of fluid accumulation within the cervical spinal cord as well. And then usually quite a marked contrast enhancement of the meninges, so a meningitis. Their ependyma, so an ependymitis, and then raised intracranial pressure with evidence of herniation as well. And so these are quite well described imaging features for cats with FIP. Now, quite often, these cats typically have a neutrophilic pleocytosis, but if we see changes as marked as this brain, then we wouldn't be taking CSF due to the evidence of raised intracranial pressure. So actually that could be quite detrimental to the patient. And so what we did is we diagnosed FIP based on the signalment blood work MRI changes. and this cat received the new and exciting remdesivir treatment and actually did very well. So this was a cat only 2 days after starting treatment. So had an intravenous course for 5 days and then transitioned onto the oral formulation, completed the 12-week course and was neurologically normal by the end of it. And we're very nearly done. So this was just our last case. So a 3-year-old male-neutered Labrador. So this dog had a history, a 24-hour history, acute onset, abnormal gait, progressing to inability to walk. So I've given you a bit less information with this patient. So you can see this, this dog had really sort of marked abnormal posture, and it also had these dysmetric movements as we were trying to examine the patient. The dog had this inability to ambulate, but it didn't really look like a typical vestibular. So there was no distinct head tilt, leaning or rolling to one side, but had these really unusual sort of limb movements. If you see in the third video, we do have posterior reaction deficits on the pelvic limbs, but they're reasonably symmetrical. And just in this last video, you can see that this dog has quite a marked vertical nystagmus as well. So this dog's sort of mentation was slightly abnormal. We had posterior reaction deficits, although without clear lateralization, and a predominantly vertical nystagmus. So we did localize central vestibular, but also with a cerebellar component, given the sort of unusual gait that this dog displayed. And actually, it's very important, remember to take a good clinical history, because it turned out that this dog was being given metronidazole and had been for several weeks. And so always remember to ask if your patients are on any medication. If this dog wasn't on metronidazole, we have an acute and progressive clinical history, so we'd have to consider infectious inflammatory disease or neoplasia in sort of this region affecting the vestibular cerebellar area. But this dog, as I said, had quite a prolonged course of it. And so we started a diazepam treatment because this has been documented in one study to hasten their recovery. And this is a dog only after 1 day of treatment. And then this is the dog on day 3 and was essentially back to normal within a few days. Lovely. So I hope that was useful. Do feel free to ask any questions, but hopefully that's made you feel a little bit more confident in terms of your vestibular patients. And I just wanted to let you guys know that I'm new to the neurology service, but we are welcoming consultations and happy to discuss anything neurological.
Thank you so much, Sarah. That was very, very useful. And yeah, especially seeing those cases, it helps a lot. Yeah, and you see some very interesting cases. I'll have a look now. I think we have one question that's come through, so we'll give people some time to write some more questions if they like. The question that has come through is about one of the more rare causes. It's congenital vestibular disease. Does that normally improve with time? And is that normally bilateral or unilateral signs?
They can do. So I've only seen a few cases of it, to be honest. They tend to improve with time, almost, I suppose, almost like a compensatory mechanism. I think they tend to get better over kind of the coming weeks to months. And I've definitely had cases where the signs have almost resolved. They are typically bilateral in the ones that I've seen, but they can be unilateral as well. It has been reported.
All right, thank you for that. And then I'll have a look if any other questions have come through. For the time being, there's no further questions. So yeah, thank you very much, Sarah, for that. Very interesting talk.
You're very welcome. Thank you for having me.
All right, so that's the end of the presentation. Thank you, everybody. Bye.